are you?
Good evening, Ginger. We're meeting on an evening for once.
We are. And you know what? In Kansas City, it is cold and we have no heat in our house today.
Well, you have no heat in your house and we have no heat outside as we just are finishing a blizzard with many inches of snow. So I hope you stay warm, Ginger. We're going to have to, talk fast so that you stay warm
I
tonight.
know. I agree. And maybe bring some of that sunshine to the Midwest here soon. We're really excited today because our listeners know that you and our guest we're bringing on, were in Haiti recently. But before we go there, I'm going to highlight some new news that maybe you and our guest don't know about. We're going to find out. There is a very famous organization called Partners in Health. They've been around a very long time, and many folks might know that Dr. Paul Farmer and some of his colleagues started this even before, I think, before he went to med school. And one of the first places he visited was Haiti, which we're going to talk about. But here is the new news. The newest release of Time Magazine's Women of the Year includes a nurse midwife from Sierra Leone. This was just released in the last week, and her name, I won't pronounce it correctly, so my apologies, is Isata Doumbouya, Director of Nursing and Midwifery for Partners in Health, Sierra Leone Reproductive, Maternal, Neonatal, Child, and Adolescent Health Program. They just started a maternal center of excellence, which opened a couple days ago.
Wow.
Project they've been working on for, I think, over a year to get to this achievement of opening their doors. And it's pretty incredible. She's actually British trained and worked in the UK 25 years before she returned to her country of origin in Sierra Leone. Remarkable story that I will put on our Buzzsprout website. But my question to you that I learned, and I watched this 90-minute video. Have you ever seen the documentary Bending the Arc?
No, that's going to have to go on my list, I think.
It is, because it is the origin story of Dr. Farmer's work and his colleagues and how they framed the problem that they found in Haiti and then developed it in, I think, 4 countries around the globe to improve health for communities. And it's a remarkable political focus on healthcare for all, but it also addresses equity and medication management to prevent death. I was blown away with watching it. It has many, many awards from the Sundance Film Festival and more, but wow.
I wrote it down, Ginger. So thank you for sharing that. That would be very fun to listen to. I think Betsy and I both know Paul Farmer. We know him personally. We've met him, and he has done so much amazing work. And I certainly always have at least one of his books on my audiobook or my shelf that I love to kind of refer to, especially just going back to Haiti. Recently, I was just listening to his Haiti after the earthquake, because I hadn't spent a lot of time there after the earthquake. It had been quite a while. So thank you for sharing that.
Yeah, I
so
just
happy
really
about the midwife of the year.
Yeah, I really thought about what could I find that's new news that you and Dr. Wickstrom would be fascinated by, and how a midwife really created this through her passion, this project with the help of that team, and it's reality. I mean, Sierra Leone is one of the worst maternal infant morbidity and mortality rates in the world. It's amazing. So there you go, Denise. Who are we welcoming today?
Well, this does give me the chance now to welcome our guest. There's so many things that I could say about Dr. Elizabeth Wickstrom, who we are allowed to call Betsy most of the time, right?
Because otherwise I think you're a telemarketer if you call me Elizabeth.
Correct. I don't even know where to start. We met a long time ago when she served as one of our collaborative practice providers at St. Luke's in Kansas City. And Ginger will tell you more about that probably. But I've spent the majority of my years working with Dr. Wickstrom, going to Haiti, working at Maison de Naissance, essentially a freestanding birth center in the rice fields of Larnage, Haiti, far from, big cities and far from any resources. And I think I could say in a few words, which would never describe all of her, but that she's fierce. She's a warrior. She has the heart of a midwife. She's generous, and she's just incredibly intelligent and giving on so many levels. As a physician, as the heart of a midwife, she really holds midwifery in her dear heart for women and birthing people, as well as for midwives that she works with. And she's a fantastic mother as well. And I hear lots of stories about her as a partner as well. So I've got to hear a lot more of those recently as we traveled to Haiti. So Ginger, what else can you add to share?
I don't want to take up too much time, but I do want to share with our listeners that I'm gonna call her Betsy from this point forward, was one of the original consultants with the first midwife practice that started in Greater Kansas City. Oh my gosh, I just lost the dates, Betsy. I want to say 2019, but I could be wrong.
No, 96.
No, it had to be
No.
before that, because you guys
Yeah.
were my providers
No.
for Elena, who was born in 1996.
Yeah, I'm like, no, that's not right. Oh, anyway, it's exciting to me to have Betsy here, because as one of the maternal fetal medicine physicians in a practice of 4 or 5, she was our medical consultant. She was the one we met with to talk about patient records and to talk about collaborative care and management plans, and was just, as Denise said, a fierce advocate not only for midwives, but for families, and for listening to what would meet the family's needs within safe care in the hospital setting. And so today we hope we're going to talk a little bit about collaboration, not only global issues, which both Denise and Betsy bring, but what does collaboration look like to her? I know she has vast experience with all types of CPMs and CNMs. And so I think that's important as we think about what the future of the maternal child health care team might look like. So Betsy, we would love for you to share with us your journey into the midwifery world and your origin story.
Well, I think probably something that influenced me heavily is that my mother was a registered nurse. Now, she did geriatric care, so she was kind of on the way out as opposed to on the way in. But I was raised to respect nurses and to understand that they had a lot to teach me. And then through residency, I met with midwives, I met with advanced practice nurses, and my goal is to learn something new every day. Doesn't matter to me who teaches it to me, but if you're open to that, you will always grow and you will always learn. And so I've had such a variety of mentors and teachers of all stripes. And then I went to fellowship, and at Northwestern in Chicago, it is the midwives that teach the med students about normal birth.
Yes.
We as fellows got to teach about the abnormal stuff. But really, they were molded by this midwifery concept that birth is a process, and most of the time it goes just fine. Is it great to have that safety net at this tertiary center hospital? Sure. But for the most part, you leave them alone and they come out. And I learned a tremendous amount about patience from my midwife colleagues. And then I came on out to the real world, and at St. Luke's, our practice manager was an advanced practice nurse, and also someone I've known forever and ever. She's been to Haiti as well, hasn't everyone? And So seeing how important advanced practice nursing is to expanding what we can do as
Mhm.
physicians, being able to see more patients and being able to give that special touch, the
Yeah.
high touch, low tech model of care is definitely something I see a lot in my advanced practice colleagues. A specifically special one to me was one of your midwife colleagues. And as I mentioned, you guys
Yeah.
were my care providers for my second birth,
Yeah.
and it was phenomenal. It was a great, great delivery. I had the best time. And when you push out a 9-pound baby unmedicated and you could say it
Yeah.
was a good time,
Yeah. There you
Right.
go.
something. And my labor nurse ended up being one of our advanced practice nurses in the office.
Yeah.
So it's just this confluence of
Yeah.
how all of this comes together that built me into the midwifiest maternal fetal medicine specialist you're ever. I don't actually wear Birkenstocks. It's a different kind of sandals, but I'm always in sandals. That's
Yeah.
a fact. And so when I went into my own practice, it was still part of St. Luke's, but I was mostly at another community hospital. I brought my midwife with me,
Yeah.
and what she did was she ran the entire gestational diabetes program. And that was phenomenal for me because it really allowed me to expand out into so many other things that I could see because it's a huge chunk of our practice,
Yeah.
but it
Yes.
bogs you down
Yeah.
if it's all you're doing. So having that strong right arm, I don't think of my advanced practice midwives or practice nurses and midwives as a physician extender
Yeah.
as much as I do my strong right arm and what on earth would I do without them.
Okay.
And so then when I really did have a solo practice, it was me and my midwife, and we had
Yeah.
this beautiful little Camelot of a practice with my two favorite sonographers, my favorite midwife that I worked with. And so I have just seen how much that means to our patients
Yeah.
to have someone who has the time and has the experience and has the personality to do a lot of teaching
Yeah.
because so much of what we do in obstetric care is all about how you eat and how you move your body.
Yeah.
And so
Very true.
now, as a telemedicine specialist for a hospital in the middle of Missouri, I
Yeah.
spend a lot of time talking about how to eat and how to move your body, and I'm sure missing my midwife for doing all of that. But it's great fun, and I have been so blessed to work with a variety of people. And I got one other thing because one day my CPM friend who does home birth all over Missouri, but a lot for the Amish community, who they really just don't come into the hospital. So if
Yeah.
they're going to have skilled care, it's going to be at
Yeah.
their house. And what she had noticed was that the transition from a home birth to a hospital birth is so often fraught,
Yeah.
and it just doesn't need to be. If we on the receiving end can have respect for that, what that person is doing,
Right.
and if they can prepare their patient in a way that they know what to expect from us, they've got the basic labs and at least one ultrasound at some time
Yeah.
ever. That's what I need to be able to
Yeah.
care for the patient. So that transition, the successful transition is something that I worked on a lot with
Yeah.
this person who also came with us to Haiti. So now we've
Yes.
come full circle to last month when Denise and Betsy went to Haiti. So
Yeah.
Great.
there you go. That was my
Thank
journey.
you.
Yeah. Well,
Oh,
I think we should throw in here too, Denise. I know that where you work, the hospital you work at, really worked hard on this smooth transition concept
yeah,
from out of hospital into the hospital setting. That's
we
not
do.
easy. That's not easy.
It took a lot of, it took some years. It took years of really kind of working with all the parties that were invested, all the stakeholders, which were all the people sending patients and moms in, the midwives that agreed to be the recipients of those patients when they came in, just to transition midwifery care out of the hospital to in the hospital. And then really just to convince our OB and maternal fetal medicine colleagues that it was a good thing to do, and it was a respectful thing to do, and it was a safe thing to do. And I remember the discussions, and maybe they bordered on arguments, and but at the end of the day, it came down to what are the statistics of when people are coming in and who are the best providers that could take care of them unless they had a need that was outside the scope of midwifery, and then we would safely and carefully transition them. So it's a fantastically like satisfying and great process that we have, yes, at the current hospital, and it is hands down the best for everyone.
That's great.
Thank you.
Well, and I think that families that are prepared for a home birth that have to make that shift, I think there's a certain amount of grief there.
Sure.
And I think you need to be prepared to walk alongside them in that grief, and show respect for them and their original plan, and show respect for the things. I mean, sometimes women are planning a home birth because they've had a terrible experience with the medical community, and they're traumatized. So if we can come at this from trauma-informed care, from that perspective, we're going to be a lot better providers for these folks. And if we can set aside our medical hat and put on our human being hat,
there you go,
and say, what would make this a better experience for you?
One of the first things I say when they come in usually is like, I know this isn't where you planned on being, but we're happy that you're here, and, let us know how we can make your stay better. And then inviting the person, that was taking care of them to come and still have a role in whatever the birth process will be, as a support, provider or whatever. And it's actually very fantastic. Everybody wins. Everybody wins. It's like the décabez, Betsy, the win-win.
Right. Double win.
That we use for Maison de Naissance, which is, everybody wins if you take care of people. The mom wins, the baby wins. And in this case, moms, babies, providers of all kinds,
communities. That mom goes back to her community and talks about this amazing experience she had with an in-hospital birth with a midwife, and that her original provider was still encouraged, I won't say allowed, was still encouraged to be with her, so she doesn't feel abandoned.
Or that she did something wrong.
Right.
Well, this is a perfect segue into how both of you took your highly educated career positions into one of the most under-resourced countries in the globe and created a safe birthing environment that is still sustained. Betsy, how many years?
We started 22. In 2004, so 22 years coming up this October.
Yeah. Can you share a little bit about how you decided this was important?
This is one of those things where you just get knocked over the head with stuff and you just have to go with it. I first went to Haiti as one of many instructors, Haitian and American, for a conference that was going on in Port-au-Prince. And as part of that conference, we ended up also teaching at the university hospital, teaching the residents. And then they're giving us a tour. And as a result of that tour, it dawned on me how little access to prenatal care there is in Haiti and how that impacts their outcomes. I knew walking into it that according to World Health Organization, they're like down on the bottom. I got that, but I didn't really have any idea why until I talked to these residents. And I said, why is it these women are having eclamptic seizures and you're not delivering them with pre-eclampsia? They don't come. And they didn't really even understand why they didn't come. That came clear later when reading a sociologic study that my neonatal friend, who was the one who wrote me into going there in the first place, Dr. Schaffer, he found this sociologic study where a sociologist had walked through village to village around Haiti, interviewing people who had lost someone in childbirth to understand why that happened. Literally everyone she met knew somebody who died in childbirth. Geez. That's how often it happens. And she described lack of education, not understanding how important it is, or what the warning signs are, or when you should go. Um, Lack of access, which could be many places charge
Yeah.
money to
Yeah.
go, and potentially more money than these people have that are
Yeah.
making $1 a week.
Yeah.
Right.
Or even if you could go, if you had the money to pay, if it's the nighttime, good luck getting a tap or a moto to take you.
Right.
Nobody drives around the hinterlands of Haiti after dark. It just doesn't happen.
Yeah.
And then also the quality of the care once you get there. And boy, did I see that as a huge problem, especially within the general hospital system supported by the Ministry of Health.
Yeah.
Um, Midwifery care is woman centered. That's why the word means with woman. That's
Yeah.
what it means. And the midwifery model from the professional midwives, from the midwife school, was very much stand at the nurse's station with your starched white cap and wait for a doctor's order. But
Oh
you're not
man.
actually caring for the patient.
Right.
And that was so foreign to me. But anyway,
Mind blowing.
back to this was March of 2003, and we're like going all over and giving our little dog and pony
Yeah.
show. And I'm realizing
Yeah.
I'm gonna have to do something about this. I'm gonna have to do something about this. So Stan and I went back 6 months later, and we're touring all around. And we went to Paul Farmer's place.
Mm-hmm.
God
Yes.
rest his soul. He passed
Mhm.
away in 2022. But even his place still didn't overcome all of those barriers. Now, one of his phrases is preferential care for the poor, giving first world care
Yeah.
in, they said third world nations at the
Yeah.
time, which we don't
Yeah.
say anymore, under
Right.
resourced nations. But the
Right.
point is, give people the care you would want to
That's
have.
right.
And that was definitely the framework that we walked into. What are we going to build? What is that going to look like? Was beginning with that idea, was that if we're going to give care, we want that to be care we would want. We want it to be compassionate. We want it to be expert. We want our people to be well equipped and well trained.
Yeah.
So what do you do if you think you're going to build something?
Jeez.
We got this group of college students, and as their project for their Globe Med Club, they walked around the neighborhood and did surveys and found out about people's um, like health already, their baseline health, obstetric care and gynecologic health, and what their family setting was like, etc. And then they asked them, if we're going to build something, what does that need to look like? What do
Mm-hmm.
you need?
Mhm.
So, although I had in the back of my mind my
Mm-hmm.
dream clinic, what I thought this should
Yeah.
look like, we didn't pull the trigger on anything until we got that information
Yeah.
and learned what was going to be important to the people that we aim to serve. We're
Right.
there to serve them. We're not there to tell them what to do. That's just, I don't have
Yeah.
that in me,
Yeah.
it's just not in me.
Yeah.
So I think that the combination of Paul Farmer attitude, surveys by college students, and then just the heart of this person
Yes.
and me,
Yeah.
just saying, we're here to serve and we want the best for these people.
Yeah.
And that's how Maison de Naissance was born.
It's remarkable.
Yes. And that is why Betsy is called the mother of Maison de Naissance.
I am. It's my official title. Je suis
Yeah.
la mère.
Yeah.
It's true. It is my third child.
Oh. So Denise, like what drew you? I know the answer, but what do you want to share about what drew you to be instrumental in the beginning of this?
I think as I describe it as being invited to come help like set up the birth center. And I wasn't told the initial plan, which I think was the plan all along by Dr. Schaffer. An invitation, oh, come and set up the birth center. You speak French and you can help us interview the nurse midwives that we're going to hire and all that. And then come to find out, I think he had other intentions of, I think when I got back to Kansas City, he's like, okay, let's meet for coffee. And I'm like, okay, sure. We would debrief about the trip, but it was actually turned into an invitation to come on as one of the first medical directors. So working with the nurse midwives in Haiti as a nurse, being a nurse midwife who spoke French, at least. I didn't speak Haitian Creole, but the midwives themselves were all French speakers. So that's where working along with Dr. Schaffer and Dr. Wickstrom became, an everyday thing for a while,
Yeah.
for several years.
Well, I think what's also important to share is the overlap that both of these physicians, a maternal fetal medicine and a neonatologist, were consultants for our midwife practice in Kansas City. So it is pretty unique, Betsy, that midwives admit and discharge the couplet, the mom and the baby. And Stan always believed in our skills. And, the neonatal nurse practitioners were available for us if we needed a consult on the newborn. It was a little sticky for a while with the pediatricians not being very happy about that hospital privilege. But in the end, for about 9 years, 10 years, it was a beautiful ability for us to provide continuity of care. And Stan went on to work with Jennifer Stevens, who some of our listeners might know, creating the Good Birth Network, which is trying to help, what, Denise, accredit global birth centers?
Right. Right. I think just an organization to help set up, standards and just a baseline of safety for each birth center should aspire to.
Yeah.
To
So a
say
lot has
quickly.
grown out of the origin story here, Betsy.
Yes.
What
I
would
think
go
when
ahead?
we talk about collaborative care, I really think that the first step, and as you said, Stan recognized this in the midwife group, the first step is recognizing each other's scope of practice,
Yeah.
strengths,
Yeah.
and talents. And we worked very hard with our staff at Maison de Naissance to help them sort of grow into their entire scope of practice.
Yeah.
And that's an ongoing thing. What we were there for in February
Yes.
was to go for some professional development and continuing to raise the standards and expand their
Yeah.
skills up to their scope of practice. We never expect them to learn to do C-sections.
Yeah.
This is a
Yeah.
No.
midwife-run birthing home. This is not a hospital.
Yeah.
Even though it's funny because the neighborhood calls it L'Hôpital Larnage, the hospital in Larnage. It's very funny.
Ah.
And you remember when we were at the airport, Denise, when the guy asked
Yes.
us where we were going to teach, and I said L'Hôpital Larnage. She said, "Oh, my kid was born there." So
Right. Right.
Oh,
Yes.
wow.
It's
that was
known for
great.
that. But I do
But
think that is a really good point, Betsy, because on this trip I saw, there's a lot of different providers than when I left, at 18 years ago, or I'm not really sure. I lost track of time, but there's a lot of different provider education levels right now. And really the goal stays the same, of training and to train to provide safe care, and really to even challenge, and this is something, Ginger, I think we've seen, is to challenge people to be comfortable
Yeah.
in the skills that they are learning in an out of hospital setting,
Yep.
to be comfortable and confident, not overreaching your scope of practice, but really practicing to your full scope of practice, because at the end of the day, there's only a certain number of people that can do that. And making sure that it's efficient, and respectful care at the same time. So we learned, a lot in this trip, which I think we had lost track of. Haiti has so many natural disasters, so it shifted a lot of how the staff shifted, the number of people that were working and the type of education that they had received. So it's certainly like, we saw how we could help them this time just work more efficiently, not duplicating each other's work, not sitting around and waiting, but also to see women quickly and to utilize more of the skills that they
Yeah.
have within themselves.
Can you share a little bit about the outcomes over? I know you have them, Betsy. How are the moms and babies doing?
so it's sort of a matter of pride, but it's also a little intimidating, I think, to the staff that we have literally no maternal deaths in Maison de Naissance. Now, does that mean nobody has received care there, been referred to the hospital, then eventually passed away? Yes, a small number of people have,
Yeah.
but zero actually at MN.
Wow.
That's good. It's great. It's fantastic. But it also puts a huge amount of pressure. If they have a patient that's
Yeah.
starting to develop even mild complications,
Yeah.
the instinct is to want to transfer,
Yeah.
transfer, transfer.
Right.
And so one of the things we're working on at this trip, and then we're going to be continuing, I got a deal with our lead midwife that every fourth Friday afternoon, we're going to do some ongoing professional development.
Mm-hmm.
And one of the things I want to really address is some of the reasons I see people being transferred.
Yeah.
Let's talk about how we could safely manage that in-house and
Yes.
avoid a transfer if we can, because the moms literally cry if they have to be transferred. Not only is it not a welcoming environment, it's not all that clean,
Yeah.
No.
and they charge money. I
Yeah.
mean,
It's costs.
so it's funny. So for years, I fought and fought and fought that we weren't going to ever charge anybody anything. So in the villages, they have these health committees, and the health committees came to our management and said, "Why do you insult us like this? Why don't you let us pay for our care?"
Whoa.
Sorry. I was being maternalistic and
Yeah.
deciding they shouldn't pay,
Yeah.
but it was actually offensive. So
Wow.
Yeah.
we have a sliding scale fee
Yeah.
for you could pay nothing if you don't have it. You can pay a little if you've got it. And they actually, through patient fees, raise about 10% of their operating expenses.
My gosh.
So there you go.
That's fantastic.
That was a good learning lesson.
Yeah, yeah. I learn from our patients all the time
Oh,
as
yeah.
well.
Yeah. What about well-intended midwives? We get these questions periodically, especially from newer grads who haven't been out in the field very long, who have no international experience at all, but have big hearts and want to go help. What advice would both of you have to how to even begin to think about making those kinds of decisions and organizations that you might affiliate with?
Well, I can speak first. Like Betsy and I probably have both always gotten the question, oh, we want to go to Haiti. We want to help out. Can we go with you next time? And it's been the longstanding focus, I would say, and goal that when we go to Haiti, even when we don't go to Haiti, when we're working with any of the staff, like myself in the first, 3-4 years when I was working with them via Skype, it was always with the intention that we upscale and support the work of the Haitians. So that we would hire Haitians, help to train them in what they're asking to be trained. And then also, Betsy will agree with me, I'm quite sure, that we push their training to a level of, higher training, higher safety, evidence-based, but always with kind of their permission or their desire, or at least their agreement, and really to make it that so that they're always providing the care, so that the care is always sustainable by Haitians and not by some other people, other cultures, other colors, other belief systems, and coming in and, putting on the Haitian populations, of which there's many different cultural things amongst themselves, which they know more than we would ever know, but really to go in and to support the work that they're doing in every way, shape, or form, from supplies to, to training. Even talking with Miss Lotine, the head nurse midwife, I said to her, I'm like, please do what you can to support your midwives that are here. There's slightly less educated. They're not all nurse midwives anymore there, but but I said, just at least support them to provide the care that they can, because you are their example, and we will support you to do that in whatever way, shape, or form you want. We will be in touch via email. We will be in touch for questions, or for the trainings that Betsy referenced, but it really is always to show them. And what I found very, very beautiful this time in a role that I wasn't a director, just going back to do the trainings, is they were seeking with great desire. They would come to either Betsy or I for consults, like, give us information, tell us what you would do. They even said at some point, this is your patient. I said, this is not my patient. This is your patient. They said, no, it's your patient. And I said, it's not my patient. I'll be gone on Friday. And finally, I agreed for that trip. I said, this will be our patient then for now. And then when I'm gone, then she will be your patient. So it was it was very fun and to work collaboratively with them, because that's the role that we should always play, I believe.
I think that's true as well. Every time I have done any kind of training or teaching, the first thing I ask 6 months before I go is, all right, tell me what you want to learn.
Yeah.
And
Yes, you do.
I swear we've learned postpartum hemorrhage every single time.
Yeah.
But each time there's been a new technique.
Yeah.
We had the last time we did postpartum hemorrhage, we had basically what is a low resource Bakri. And
Yeah.
this time we taught a low resource Jada.
Yeah.
So,
Right.
Yeah.
you know, the idea is to keep layering the training.
Yeah.
But it was one of our founding principles to
Yes.
always hire Haitians, always,
Yeah.
and improve the community by hiring from within every chance we get, and
Yeah.
listening to the community. So I think that's been integral to why we've been successful. One of my favorite stories, before we even opened, is that we had this huge container, shipping container of furniture and equipment and all the things from my two different hospitals that were redoing their labor and delivery units and had no place to put their stuff. I'm like, I'll take it. I'll take
Yeah.
that.
Yeah.
And so the truck is coming from Port-au-Prince, and it is the raining season.
Oh, gee.
And what serves as a road there
Yeah.
in
Yeah.
rural Haiti, like
Yeah.
there's potholes
Ruts.
that could swallow a small
Yeah.
car,
Yeah.
and the truck got buried to its axles in mud and
Oh my gosh.
could not move at all. The neighborhood, their surrounding villages came out and made a human chain, unloaded the truck into like a quarter mile away
Oh my
to
gosh.
the birthing center, carried exam tables and hospital beds and just hugely heavy things, like 5 people on a
Yeah. Yeah.
and to me that speaks to the buy-in.
Right.
And
Oh yeah.
that was before we even opened, and it just continues.
Yeah.
Yes.
Well, one of the things before we transition maybe to some domestic conversations as a maternal fetal medicine doc is it okay with you if we put the Maison de Naissance website on our marketing materials, our Buzzsprout website, and can people give donations there if they would like to? Is there a portal?
100%. It's going to say donate now, and you just click right there.
All
And
right.
there's various ways to
What
do
a
that.
question, Ginger. Of
Well,
course.
we have to capture this moment because I am so proud of these two women in front of me who bring such energy, passion, and commitment to continuity of care for so many years. I mean, there aren't a lot of places that have replicated this model that has been able to be sustainable. And I mean, it's a big job, fiscally as well as ongoing training.
And some of it's just sheer stubbornness. There have been,
Sure.
there have been so many setbacks and so
Yeah.
many things that could have just done us in, and we just refused.
Yeah.
My executive director would say, do you think we need to cut back on our services? I said, no, I will give more. He's like, you can't give more. I said, I can give more. It's going to be fine.
Betsy.
And we just kept going.
Yeah.
Because I don't really see any other option. I don't
Yeah.
see us
Yeah.
stopping.
Yeah.
What would those people do
I know.
I mean,
without
Betsy,
care?
almost 500 deliveries a year at that birth center alone.
I was going to ask how
It's
many.
it's not just births. It's
Yeah.
it's HIV services, it's community health services, it's vaccinations, family planning. I mean, I don't know what they would do either, Betsy. And you have really been always there. And I will always want to be there as a part of it, to help you. But, it's really important, the repetition of
Yeah.
trainings, the repetition of
Yeah.
donations, supplies are always needed. So human resources and human supplies, I mean, for our humans in another region is just important.
Yeah. Yeah.
Agreed. I appreciate you asking, Ginger. Thank you.
Sure, we will do our best to promote that. So maybe for the last part of our conversation together, I'm sure you know, Betsy, there's still, even though there's an incredible workforce shortage, there aren't enough physicians, there aren't enough OBs, there aren't enough MFMs, there aren't enough midwives for the demand of women needing a variety of healthcare services. And yet, in America, we still seem to have these incredible barriers. I don't think we have a critical mass of our profession yet. It takes about, everything I read, delivering 18% of the population for America to really know what a midwife is, and we're not there yet. We're at about 13. What ideas might you have? We're going to go on the see if we can help people side. What ideas might you have as a physician to help the midwives struggling to convince physicians or even get them to engage in a conversation about collaborative care models? And are there things you've learned that maybe could be helpful?
I think it's not just the physicians. I think it has to come from a government perspective,
Okay.
the recognition of maternity care deserts,
Yep.
and that. So I was looking up some stats before we came together here. Overall, in the United States, there are 38 practicing OBGYNs for every 100,000 women, and they're mostly in
Yep.
the cities.
We
You
just
have
talked
this.
about this on our last
Mhm,
podcast. Yep.
mhm. Nearly half of counties have no practicing OBGYNs.
Right.
7% of American women live in a county with no OBGYN. So
Yep.
how do you say that the OBGYNs are going to be the only ones providing care? That is
Right.
nonsense.
It's not possible.
So, recognizing that we need to expand our workforce, that needs to include family practice people that have
Yep.
OB certification, that needs to include potentially nurse practitioners at health departments
Yep.
providing prenatal care, and then they refer in
Yep.
to an OB provider or a birthing center. But we need to grow more birthing centers, and we need to empower our midwives of all stripes. There's CNMs, CPMs, CMs, and in Missouri,
Right.
yes, we do have certification through it's NARM, whatever that stands for.
NARM. Yeah.
Yeah, for NARM. And then there's also Missouri Midwives Association that can, like, you can look it up on their website and say, okay,
Yeah.
what midwifery practices are there? And some of those are CNMs and some of those are CPMs. And they're a different animal.
Yeah.
So just like the staff at Maison de Naissance, infirmière sage-femme is someone who has a nursing degree who then went to midwifery school and then did a residency, a stage, and then
Right.
practices.
Okay.
And there's a second group of midwives that are trained on more of a apprenticeship
Yeah.
practice through Midwives for Haiti. They're still midwives, but
Yeah.
they didn't start with a college degree. They
Right.
started with more of a high school degree
Right.
and then went through 18 months of training to learn how to be a midwife. There's a whole different category of people called auxiliaires who are more
Yeah.
like our MAs,
Yeah.
and they did
Mhm.
more on the job training. They don't have necessarily any certification, and it takes that whole team to
Yeah.
run Maison de Naissance. And if I could just plant that idea in our boards of registration, our health
Yes.
boards in state by state and also nationally,
Yep.
to understand that it really does take the entire team
Yep.
to help spread that care out through these maternity deserts. And that's the only way we're going to start decreasing our maternal morbidity and mortality, which is scandalously high
Yeah.
for such a
Yeah,
wealthy
correct.
country.
Yeah.
Yes.
What one of our partners says a lot, Leslie Rathbun owned the Charleston birthplace for many, many, many years, maybe 16 years. And when I hear her talking to some of our potential clients, physicians and hospitals who are still trying to figure out what they want to do, one of her examples is, we put EMTs out in ambulances to save people with heart attack and major trauma who are doing an unbelievable amount of procedures as they're calling in the status of the patient, and they elevate, care to the next level as needed. And why we haven't quite figured out that midwifery care can be stratified in such a way with seamless levels of care as needed is just beyond me, Betsy.
Beyond me.
It's territorial. It's a pissing contest. It's, I'm gonna like stand on my MD or DO laurels and look down on everybody else. A little bit's the almighty dollar,
Yeah.
Oh, of course it is.
because if you
Yeah.
are sharing the load, you're also sharing the take.
Yeah.
But OBs don't want to go out to outer hinterlands of
Right.
Missouri and provide that care. They don't.
Right.
Or
So
any
why,
hinterlands.
yeah. So why mess with the people that do want to do that? Let's bring them in.
Yeah.
I really do think, training having rural programs is one way of doing that, to bring, it's taking care of the communities in which people come from, and doing it in a way where there's good education and good accountability, I think is a win-win for all the people that would be served by it. So that's my dream, is like having really good rural programs that will take care of these, all the
Yeah.
moms and babies in these areas.
Well, what we have, I think, trying to emerge, but in my opinion, the piece of the puzzle is still missing. We have all of these femtech companies starting up, right? Telehealth is like vogue now in maternity care, whether it's prenatal support, postpartum support, virtual, coaching for what your needs are through the pregnancy. I think that's fantastic. I personally think it could be stronger if we did what the midwives in Scotland and England do, which is give Denise her iPad, send her out, 3 hours away, go do the prenatal visits, and let Denise tell you, Dr. Wickstrom, what's going on with the patient, maybe do a scan,
Yes.
portable ultrasound, all kinds of technology that could be used with human contact. That's where I still struggle, Betsy, is what might we be leaving out in the clues of risk prevention or reduction?
Yeah. Because though I love doing telemedicine, my favorite is if I actually do a video visit in people's home. You get a
Yes.
whole
Oh, yeah.
different view of them than if they got all gussied up and came to the doctor's office,
Yeah,
Um,
that's true.
Sure.
So I love video visits at the home because that's where the real care is happening.
It is.
And when they come to the office, there's a real nurse that's actually taking
Yeah.
vitals and taking their history, and there's a real sonographer laying
Yeah.
hands on them and showing me the images. But I love that idea that you've got your ultrasound probe that goes to your iPad, and you
Right.
got your electronic health record on your
Yeah.
iPad, and then all of that, comes back to some central depository, and
Exactly.
yeah,
You can even
I
do
love
your,
it.
NST out there. I mean, all
Yeah.
the technology is available, but no one, the three of us should invent this model. I'm just saying.
I mean,
Just
I
saying.
think a lot of people are listening to it though now. But
Hey.
I do think the point of linking that, you can have all the technology, but summarizing what you're saying, Ginger, is linking that to then the humans that can
Yes.
interpret it, identify
Yes.
the risks, and provide some guidance for care, and then routes for them to be able to access that care when the need be is
Yeah.
really important.
Yeah.
Yeah.
Because I think the person who is the adhesive, I was going to say glue, but I just watched the documentary, right, about the origin story of the ARC. The community health workers and the doulas existed in parallel worlds at about the same time, but they were doing different things. The community health worker, correct me if I'm wrong, were really out there moving HIV prevention and in convincing families to take the medication, to be consistent and give them immunizations, while the doula was over there in South America, sitting in a room, just being in the room, but being there at a time of labor. And yet we still haven't quite adopted, in my mind, for these two potential roles in maternal health care to be recognized providers who can say, Dr. Wickstrom, I saw Denise today. I really think you need to know about this. And how does that all work with the world of HIPAA and licensure and regulation and
reimbursement?
It's a hot mess.
Yeah.
And
Yeah.
yet
Well,
they're
it's
very
funny
crucial.
because insurance companies are paying doulas.
They are, but not to talk to you.
Right. Right.
Right.
I mean, they can explain to the patient, hey, you need
Yes.
to call your OB about this.
Yes.
But then she goes and leaves a message at the OB office. But if it's after 4 p.m., we'll call you back by 4 p.m. tomorrow.
Right.
And there needs to be a more direct line. I agree.
Yes. Yes.
Yeah. I think it's regulatory, and we haven't figured it out yet. But these aren't new concepts. It's community-based support.
All over the world.
I know.
All over the world, people are doing this. Why are we so backward?
Because we're still researching. We're still spending money researching instead of putting the money into.
Yeah. Yeah.
It's time to do the work, right? It's time to do the work.
So I feel like we need to decide what this needs to look like. And then we need to find ourselves a legislator. And we need one in Kansas and one in Missouri to champion this idea. And we'll just feed them the facts and feed them the process and say, listen, make some legislation, and we'll get people behind it.
We may have a little bit of an in Kansas, Betsy. Tara Stroda, a nurse midwife that graduated from KU, coordinates the Kansas Perinatal Quality Collaborative, and we had a very, very effective call with the TEMA team at KDHE last week. I think we level set. I think there's some readiness to listen, and I think this is a great idea.
Love it.
Because what I'm learning of the 15 states that were awarded $17 million to think about what they want to do for 3 years before they ever implement anything in the last 7 years is a waste of time and money. We know the answers. We're not going to Haiti. I mean, what do we have? 34,000 births a year in Kansas? I don't even know how we got the grant, to be honest with you. But that set aside, we have experts in this state who could really help influence the direction of getting it right instead of guessing.
Right. Correct. It's a convening of people now that needs to happen.
Yeah. And
a convening of the experts.
Everything is slowed down because of political topics we don't have to go into right now. But the technical assistance has been slow. The rolling out of the money has been slow. The guidance, has been slow. And I think that has impacted, but most of the states have not contacted their local ACNM affiliates. So I'm challenging all those folks that got money. You better go make your own call because they're not going to come to you.
Nope. They've been smacked down too many times.
They're not going to come to you. Well, we're close. We're close, Denise, to, wrapping it up. But what's really important, and I've actually heard from some of our listeners, their favorite parts is the call to action.
Oh.
Yeah. So what order do you want to do, Denise?
Well, I think I called you out last time to go first because you were always calling me out. But I think Betsy, because you're such a strong and powerful person and very smart, we're going to ask you for your call to action.
All right. I actually had 4.
Good. Whoa. You were planning it.
I did. I believe that women in Kansas and Missouri need to seek out midwife practices for their own care and for their loved ones. And they may qualify or they may not, but they're going to benefit if they qualify. And so I would encourage all my pregnant friends and family to follow my lead and be cared for by midwives. I mean, John was like, why would you go to a midwife when you could go to a doctor? You're a doctor. I said, yeah, exactly. They said, why do I need a doctor? Because I am one. I need a midwife.
Right, right.
Support candidates who advocate for reproductive rights. We have got to flip the supermajority in Kansas, 100%. Promoting legislation that improves access to care and fair compensation. We've kind of touched on that a little bit.
Yep.
Supporting food banks and mutual aid organizations. If anyone has shown us how to do that, it's Minneapolis.
Yes.
They've turned neighboring into a verb.
Yes.
And we need to all be about the acts of neighboring.
Oh, wow. I just got goosebumps, Betsy.
That one's a good one.
Yeah.
And there are neighbors in Wisconsin, my neighbors.
Right.
We're so proud of Minnesota. It's ridiculous. Yeah. Very good one. Thank you, Betsy. I don't know if we got to your fourth, but at least those are
that
three.
was it. Yeah, you got me.
All right, Ginger, you're on now.
I am. I'm going to take away from this something that I think is sometimes difficult for people to hear, but I think it's important for self-reflection. And that is if your passion and if you want to call it your calling is giving you the sense of doing international health, pause for a moment, investigate the organization you might be going with, learn about their history in that setting and in that community, and ask questions that will help you better understand the mission, vision, and value synchrony. Is this for Americans to go, come home and feel good? Or is this for Americans to go and facilitate what the community needs? And I think Denise and Betsy really highlighted that, but I personally believe we can do more harm than good if we don't understand what we're walking into, despite our passion and our belief that we can save a life. So I'm gonna leave it there. Denise?
All right, so I'm last up. So I think the thing that that's coming out of this for me as well, but something I have really been thinking about a lot is how we need to really look at our communities first, and whether that's moms, babies, and other midwives of all different kinds, like get connected, learn where people are at, invite people to the table, have discussions, and really learn to support different healthcare providers that are trying to do work in silos, isolated areas, because I do believe that coming together really, really can create so much more benefit. So I think that's my call, is really focusing on the community and how to therefore then improve far-reaching communities that we might not have contact with.
Great, Denise. So we're going to end by sharing that on our Buzzsprout website, we will place Maison de Naissance. I think I say that right.
Pretty great.
Their website. So if you want to contribute and support the work, these two amazing people and the entire team, there's a way to do that. I'll also put up the link to the documentary Bending the Arc, if you want to know more about Dr. Paul Former's story and the origin of the work, Partners in Health. And we just want to thank you, Betsy, for being with us. We're
Always
very
a
new.
pleasure.
You were very new on this journey. And
Yes.
we thought, wow, what a great opportunity to talk to both of you at the same time.
Oh, my pleasure. I do want to
Thank you,
clarify one
Betsy.
thing. The name of the birthing center is Maison de Naissance, but the foundation is Global
Yes.
Birthing Home Foundation. Just in
Thank
case
you.
people go to the website and they go, I thought this was Maison de
There
Naissance.
you go. That's great.
Nobody could spell Maison de Naissance, so we had to pick a new name.
We'll make sure that's clear too on our post. Thanks so much. We love
Thank you,
having you
Betsy.
here.
Thanks for having me, guys. It was a pleasure.
Denise,
It's always a pleasure.
our
Let's keep
next,
doing the work.
absolutely. Our next podcast is going to be getting into the grit of some of the challenges we've been hearing about the last 6 weeks or so, and that's midwife offers that are slightly less than good.
Well below what they should be.
Well below what they should
so
be.
many levels.
Yeah.
Kind of, let's just face it, kind of ridiculously disgusting.
All right.
All right.
Well, goodbye, everyone, and have a great day.
Thank you.